Good afternoon, everyone, and welcome to today's Epicenter Psychosis Speaker Series. I'm delighted to introduce our distinguished speaker today, Dr. Judith Cook. Dr. Cook is a professor of psychiatry at the University of Illinois at Chicago and director on the Center for Mental Health Services Research and Policies, one of the preeminent research and development hubs really internationally around the development and deployment of tools and strategies to facilitate the recovery of individuals with serious mental illness. Because of the success of that center, I imagine that many of us on the call here today liberally utilize strategies and skills that have been developed there in our work or in our own recovery here. And we're absolutely delighted to hear about some of the new work coming out of Dr. Cook's shop around peer-delivered health education for individuals with a serious mental illness. As always, we'll have a few minutes for questions at the end of the session, and questions can just be sent into the chat feature to me. But with that, I'm delighted to turn things over to our distinguished speaker today, Dr. Judith Cook.
Thank you very much, Nick. I'm very pleased to join you all today to describe Whole Health Action Management, or WHAM, and tell you about a study done at the UIC Center on Mental Health Services Research and Policy. But before I begin, I'd like to acknowledge study funding from the National Institute on Disability, Independent Living, and Rehabilitation Research of the U.S. Department of Health and Human Services and the Center on Mental Health Services of SAMHSA. What I'll be presenting today does not reflect the opinions or endorsements of any federal agency, however. And also, I have no conflicts of interest to disclose regarding today's presentation. I'd also like to acknowledge the organizations that were involved in developing and studying WHAM. One is the Georgia Mental Health Consumer Network with Shuri Jenkins Tucker, Jackie Wolfgang, and their colleagues. I hope I have some other Georgians on the phone or at the webinar with me today. Another is the Appalachian Consulting Group with Ike Powell and Larry Fricks, the WHAM trainers. And the third is the Georgia Department of Behavioral Health and Developmental Disabilities with Wendy Tygreen. And three community mental health agencies I would like to acknowledge. It's where we taught WHAM during the study, and they were also critical partners. They are the Community Friendship in Atlanta, Thresholds in Chicago, and Trilogy Behavioral Healthcare, also located in Chicago. Let's look at the learning objectives for today's webinar. First is becoming familiar with WHAM's purpose, content, and organization. Second is developing an understanding of how WHAM teaches people to enhance their health and well-being through person-centered goal setting, weekly action plans, peer support, and science-based principles of resilience and whole health. And third, you'll discover how you can access more information about WHAM and how your workforce can become trained and certified to deliver it. WHAM is designed to help people with mental health and substance abuse disorders enhance their physical health and wellness. It was developed by people in mental health recovery, and it's designed to be co-taught by two trained peer specialists. It uses a peer support, recovery-oriented approach to help people create new health habits based on their interests, strengths, and abilities. This point is central to how WHAM works. A key feature of WHAM is that it doesn't focus on changing existing habits, but instead it shows people how to build new healthy habits of their own choosing. WHAM has 5 essential components. The first is a person-centered goal that people create after receiving education about whole health and resiliency. Second is a weekly action plan of small steps that lead toward goal achievement. A daily personal log helps people keep track of and document the steps they're taking. At weekly WHAM support groups, people discuss their progress toward goal achievement and receive support for healthy lifestyle changes. This also occurs during one-on-one meetings with one of the peer specialist teachers from the group. Here are the topics that people learn about as they're choosing their goal, including restful sleep, good nutrition, physical activity, managing stress, being of service to others, the value of a support network, the role of optimism in health, how to change negative thinking, spirituality, and having meaning and purpose in one's life. One key learning in WHAM is the relaxation response, first studied by Dr. Herbert Benson at Harvard's Benson Henry Institute. The relaxation response is an essential resiliency tool that uses the parasympathetic nervous system to relieve stress. Participants in WHAM learn how stress affects the body, increasing blood pressure, heart rate, breathing speed, and blood vessel constriction, and the negative effects on the body of these responses over time. They learn to use relaxation techniques that counter these effects through combining meditation, controlled breathing, and muscle tightening and release. They also learn about research showing that the relaxation response improves health conditions caused or exacerbated by chronic stress, such as fibromyalgia, insomnia, hypertension, and others. Another key learning in WHAM is dealing with negative self-talk to create a sense of optimism flowing from positive expectations. Participants first learn about the well-documented link between a positive frame of mind and good physical and emotional health. They also learn how negative thinking is enhanced and perpetuated in a spiral that leads to self-reproach and inertia. Then, participants learn a CBT strategy that some of you may have heard of called Catch It, Check It, Change It, to reframe negative self-appraisals by comparing them with factual reality. So instead of, my skirt is too tight, a fact, leading to a negative self-appraisal, I'm fat and ugly, people learn how to replace the appraisal with a reality statement such as, I have other skirts that fit well, or if I move the button, the skirt will look much better. People learn this and other cognitive strategies to interrupt the negative thinking spiral and replace it with a sense of gradually increasing optimism based on positive expectations. In this case, expectations about becoming healthy. Yet another key component of WHAM is the impact goal setting process. I'm sure you're all familiar with the component of structured goal setting in positive psychology as a strategy for health behavior change. WHAM participants are helped to identify a goal that improves their health, is measurable, is positively stated, is achievable given their life circumstances, calls forth some types of behaviors, and can be completed within the class time period. Once people have chosen their health goal, they create a weekly action plan, which is another one of the model's key components. The plan consists of action steps toward their health goal that can be accomplished in the next 7 days. They also rate their level of confidence in being able to carry out their plan on a scale from 0 to 10. They share their plan and confidence rating and get supportive feedback. Then the following week, they report back to the group or in their individual meetings, which I'll talk about in a minute, on the success of their action plan. They get support regardless of their level of success or failure, and then decide whether to continue their plan or revise it for the following week. I'm sure you recognize, if you're familiar with motivational interviewing, the techniques of motivational interviewing that are involved there. These strategies are designed to create small successes, to teach people about their potential for behavior change, and to provide the structure for moving forward toward goal attainment. Let's take a look at a couple of sample health goals and action plans to illustrate this process so that you can understand a little bit more about how WHAM works. This individual ate junk food at pretty much every meal. Pop-Tarts for breakfast, frozen burritos from the dollar store for lunch, and fast food hamburgers or fried chicken for dinner. He had the goal of adding 2 nutritious foods to his diet 3 times a week that he wanted to accomplish by the end of WHAM classes. So that is his big goal that he wants to reach at the end of classes. Notice that this goal met the requirement of being positively stated. He didn't say, for example, I'm going to stop eating junk food. Also, it's measurable. It involved actions on his part. It would improve health quality, and it met other impact criteria that I mentioned on the last slide. There were a number of action steps needed, and the first was to get ideas about what would be nutritious, but also something he really wanted to eat. One of the things WHAM teaches is if you feel you should do something but don't really want to do it, that's not a good goal for you. So he had to check out a book about low-fat, low-salt diets to see if there were some things that he could eat in those diets that appealed to him. He also needed to be able to afford these new foods, so he had to find a reasonably priced local grocery store. No more shopping at the dollar store for his nutritious foods. His plan was to buy ingredients that enabled him to add, so this is now his weekly plan, weekly action plan, 1 nutritious food to one of his meals during the week. So notice he's starting very small with this. 1 meal, 1 nutritious food. He also had some affirmations about healthy eating, another technique, cognitive behavioral technique that is taught in WHAM. And he found these affirmations online, and he was going to repeat these to himself once a day. And I found it compelling to hear what affirmations he used. And there were 3 of them. I am worth the time and money I invest in my health. Another was, I'm learning new things that heal my body 1 step at a time. And a third was, healthy food tastes great and nourishes my body. This participant was a woman who was obese and very sedentary. Her goal, again, by the end of WHAM, was to add a 30-minute walk to her routine every other day by the end of the WHAM classes. So this is her first weekly action plan, and I think it shows what a great planner she was. She really got the concept of action steps and breaking things down into small steps, down to deciding what shoes and clothes she could wear to be comfortable and getting those ready. She lived in a sketchy neighborhood, so she wanted to pick a location where she could feel safe walking and a safe route to get there and back. She also wanted to practice the relaxation response whenever she started to feel anxious about leaving the house for her walk. She knew that finding a friend willing to walk with her would increase her chances of follow-through. So for her first weekly action plan, and that's what you're looking at on this slide, she intended to walk with this friend twice for 15 minutes. So again, a much smaller component of her eventual goal of walking 30 minutes every other day. Completion of the daily log is another key WHAM component. Doing this reminds people to think about their goal and action plan every day. They record anything they did that day to further their goal, as well as the amount of effort it took, and any obstacles or facilitators they encountered. So each day, people are asked to think about what I did today in relation to the goal and action plan, the amount of time I spent or the number of things I did toward my goal, and what helped or didn't help me follow through on these things. So that's the daily log. So I've given you an overview of WHAM's content and some of its active ingredients for health behavior change. What I'd like to do next is describe the WHAM delivery format that we tested in the research that we did in our center. You can actually teach WHAM for a month. You can teach it for 2 months. We taught it for 3 months. But what's nice about the curriculum is it's modularized so that you can take a session and divide it into 2 if you want to have briefer sessions, for example. What we tested ran for 3 months, and it involved 3 months then of group WHAM support meetings and 3 months of individual meetings between WHAM participants and one of the 2 teachers. So let's start with the group meetings so that you can become familiar with those. These were led by peers who had been trained to deliver WHAM by trainers from Appalachian Consulting Group. I mentioned them earlier. They're the trainers that train certified peers to deliver WHAM, and they certify them to do that delivery. The first 3 group sessions lasted 2.5 hours. We were able to do it in that format because it was a research project, but if you were doing it, you might want to break those in half, or maybe into 3 sessions if you're more used to 45-minute sessions at the program that you're working at. The reason why those first 3 sessions need to be longer is you're educating participants about what whole health is. As I talked about, you're talking about things like the relaxation response, and you're teaching people CBT strategies. You're getting them familiar with the idea of what whole health goals are and what action plans are. And you're also getting the group used to giving and receiving peer support. And for some people, this is kind of new. They're not used to being in a group that's taught by peers. So we need to allow adequate time to have all that happen. Now, sessions 4 through 12 are shorter. They lasted in our study for about 90 minutes. In 4 through 11, people learn about a series of special health and recovery topics, such as the power of peer support, why it works, and why you might want to reach out to peers, not just for your health and wellness, but in other areas of your life, like finding a job or finding a place to live. Also, talking to your doctor is one of the special recovery topics, and also recognizing recovery, being able to recognize the small steps that are leading to you putting your life back together. Session 12 involves a graduation celebration where people reflect back on what they looked like when they started WHAM, how they feel both emotionally and physically now that they've done WHAM for a number of weeks. And we always served, before the pandemic, a healthy snack, usually healthy cupcakes. You can't do that if you're delivering it virtually. But it's important to have that graduation. And we also sent people, or gave people, because we did these classes live, it was before the pandemic, we gave them certificates in frames. And this was really important because people had invested a lot of time and effort in coming to WHAM and working on action plans and keeping their daily log. So they were very gratified to have a certificate with a seal on it. And for some people who hadn't had a lot of advanced education, this was very, very meaningful. Some people brought family members or their clinician to the graduations. So it meant a lot to people. Let's turn next to the individual meetings. Those occurred with one of the 2 teachers in any day following the group meeting. So the idea is you have a group meeting, people learn certain things, and then the individual meeting follows that. The first 3 individual meetings lasted about 45 minutes, and this allowed time for the participant and the teacher to build a trusting, supportive relationship, and also provided an opportunity for the teacher to review with people things that were taught in the class that might not have been fully understood or maybe were confusing. It also allowed the teacher to be able to take things learned in the group and personalize them for that particular individual. For those who wanted it, These one-on-one meetings were also a time for additional peer support around issues related to health, mental health, and other life areas. So the one-on-one meetings were important, and some people that teach WHAM are inclined to not include these, and we found them to be an essential part of WHAM. The remaining sessions after the first 3 were much shorter. They lasted for, on average, 15 to 20 minutes. They could be as short as just a 3 to 5 minute check-in, depending on what was going on with the individual. And so it was really only the first 2 that were, somewhat lengthy. Another part of the individual meetings that I wanted to mention were the weekly health check-ins. These were used to see whether the individual might have upcoming medical appointments and discuss how to prepare for them. We learned that many people were not very empowered in dealing with their medical doctors. They weren't used to, for example, making a list of questions that they might have for the doctor. They were not used to thinking about what medications were prescribed that they were taking and weren't taking. We wanted to move people away from the idea that it's not about taking everything that you're prescribed. It's about looking at, if you're not taking some medications, why that is, and sharing that with the doctor so that maybe the medication could be changed, or the doctor can at least be aware of the fact that that medication isn't working for you. So some folks were very much into a routine that we assume they might have learned from the very quick meetings with psychiatrists that they had, where they came in, said a few things to the doctor, got a script, or got a therapy that they were going to follow up on for a physical, because again, these are meetings with their medical doctors for a physical complaint, but they weren't really used to dialoguing with doctors. And so there was, in the one-to-one meetings, suggestions for doing that, helping people make lists of their medications, which were working for them and which weren't, and also lists of questions that people might have about their medications. Sometimes people needed to see a doctor, and what was needed during the health check-in was helping them find a doctor, either that they could afford, or a doctor that took Medicaid, or a doctor that they were able to get transportation to. So sometimes that was what was necessary as part of the health check-in. And sometimes the peer helped people make their medical appointment if they were having difficulty doing that, or if it was confusing, if they were getting the runaround at a clinic, or if they didn't have the right identification and couldn't seem to get anyone at the clinic to help them figure out what identification they needed. The peer would help them get that information and help make sure they could make that actual appointment. So the health check-ins were important. Not everybody needed them. While everybody had a medical comorbidity who came into the study, some people, they had high blood pressure, but it was under control, for example. So they didn't need this kind of intensive help with dealing with medical doctors that I've described. I'd like to tell you now a little bit about our randomized controlled trial of WHAM, how we conducted it, what we looked for in the way of outcome measures, and what we found. So we recruited 139 research participants from the Atlanta and the Chicago programs that I mentioned at the beginning of my presentation. And we randomly assigned 68 of them to WHAM and 71 to services as usual. And the services as usual group also received a gift card for $35 that they could spend on their health, because they weren't going to get the WHAM classes. And they also got a health manual tailored for men or for women. So it was what's called an enhanced services as usual condition, but it didn't include any of the elements of WHAM. Then we delivered 3 months of WHAM group and individual meetings to the individuals who, 68 individuals who were assigned to the experimental condition. Everyone, both conditions, participated in 3 paid interviews at the time they came into the study. 3 months later, which was for the experimental group when they had just finished WHAM classes, and then 3 months after that. And that third 3-month period was to do a follow-up after the classes were over to see if people were able to maintain any of the gains they might have made during the classes. So that's why we had 3 sets of assessments. We also collected data on attendance, and we assessed fidelity to the WHAM intervention. Fidelity is a very, very important aspect of research, for sure, but if you're going to deliver WHAM, fidelity is also a very, very important concept in making sure that WHAM's delivered in the way it's supposed to, that people follow the curriculum and don't go off and start teaching something that's been helpful to them but isn't really part of WHAM, and also that they follow the WHAM principles in making things being positively worded and developing new health habits that people really want to do versus many people wanted to quit cigarettes, for example, and that was not a goal that we encourage in WHAM because it involves taking something away. So instead, people were helped to come up with a goal that would complement reducing their dependence on cigarettes or complement engaging in a smoking cessation program. So that's a good example of one of the finer points of following WHAM principles. We measured in our study 4 participant outcomes. And the primary outcome was something, I don't know if you're not a researcher, if everyone will have heard of this. It's really important in health research, and it's called patient activation for healthcare. And patient activation is, once I explain the concept to you, for those of you who aren't familiar with it, you'll see why you need an activated patient in order to have someone take care of their healthcare. Because someone who's an activated patient, first of all, believes that they're the major person responsible for them being healthy. Not the doctor, not their family, not their medications, but they're in charge of helping to keep themselves healthy. An activated patient also believes that they have the ability to monitor their health, to notice slight changes in the way they're feeling and the way they might be behaving in regard to their health, and that they are empowered to decide which of those changes they want to share with their doctor so that they can work with their doctor to monitor changes in their health. Also, an activated patient is someone who feels that they can take action to stay healthy. That doesn't mean they can never do something unhealthy, but they have the ability to be on track most of the time, even during periods of stress. And that's what's very important about health activation. Many people can be healthy, but then when they run into a stressful period in their life or something happens in terms of a change, even if it's not related specifically to their health, and then they lose that sense of being in charge of their health and being able to engage in healthy lifestyles. So an activated individual is somebody who knows they're in a period of stress and is still trying to maintain their healthy habits as much as possible. I think any of us who have tried to continue our exercise routines during the pandemic, or maybe has tried not to engage in eating too much junk food or overeating during the pandemic, that's a good example of being an activated individual during a period of high stress. In addition to patient activation, we also measured 3 secondary outcomes in our study. One was people's ratings of their general physical health. Another was how hopeful they felt about their life. And really the hopefulness concept was life in general, not just hopefulness about their health, but hopefulness about the fact that they could have a good life, that they could improve their life, and that they had a sense of control over how their life would turn out. And finally, we measured 2 rehabilitation outcomes. The first was paid employment. I don't know if you're familiar with the research on the critical relationship between health and paid employment, but we hypothesized that people that were feeling healthy, even after only 3 months of feeling healthier, we felt that they would be more likely to be able to engage in paid work. And another rehabilitation outcome that we measured was whether people were able to live independently, because being healthy is also a major predictor of whether people are able to live on their own, engage in activities of daily living, and live in settings that don't require additional services and supports. Another thing that we measured and that I'm going to share with you is people's satisfaction with WHAM. We wanted to know whether they felt it was helpful. We wanted to know whether they liked the group and the individual meetings. We wanted to know how they felt about the peer support elements of WHAM. So we really wanted to get a sense of what they felt were the enjoyable parts of the intervention. Now, I mentioned that I was going to say a little bit more about Fidelity, and I'm focusing on it because if you're thinking that you might like to implement WHAM at the program where you're working, you're going to want to pay attention to Fidelity and making sure your WHAM teachers are monitoring Fidelity and get support to maintain Fidelity. Fidelity is just a fancy word for making sure WHAM is being taught the way people have been trained to deliver it. So in other words, do they deliver the intervention content using the prescribed teaching activities? Do they adhere to the intervention's principles? Those are sort of the major elements: content, teaching activities, principles. And this is important whether or not you're doing a research study. In our study, we measured Fidelity in 2 ways, and this slide provides information about one of these ways, and it's the way you'd probably use if you were introducing WHAM at your agency or program or across your system, if you're a system administrator. And it involves the use of checklists for each session that measure whether the session's topics were covered, whether the teaching methods were used. For example, you're supposed to lead a discussion, and if nobody wants to discuss, it's important that you try to get a discussion going. And so, because part of what people learn from WHAM is through sharing and personalizing. So it was important to make sure the discussions were happening, and also the time frames. There's a recommended time frame for every activity in WHAM. And we wanted to make sure people were concentrating on the hard stuff as well as the easier stuff. And so that was one of the things that was measured through the checklists. So the checklist was completed by a research staff member with one of the teachers, you didn't need both of them, within 48 hours after the session ended. And this was done over the phone. And the score was simply the percentage of required features for that session that were present. So for example, if you got 100% for session 2, that meant you taught all of the content, you used all of the teaching modalities that you were supposed to, and you adhered roughly to the timeframes that were suggested for session 2. If you got a 50% Fidelity score for session 2, that meant that you only were able to teach about half of the content and half of the use half of the teaching modalities and so forth. Fidelity isn't always totally under control of the teachers. Sometimes there was a fire drill, so it wasn't possible to cover all the content. So one of the things that assessing Fidelity does on a weekly basis is making sure that if something was missed in a class, the teachers would go back at the next class and be sure to cover it. Because WHAM builds on, each subsequent class builds on things learned in the class prior. So it's important that none of the content get missed. Our Fidelity results showed that teachers delivered WHAM, again, this is in our study, with a very high degree of fidelity, with average Fidelity scores ranging from 97% to 100%. And this was true across the different classes that were taught. It was true across the different teachers that were teaching WHAM, because we looked at Fidelity by teacher. And it was also true for the different sessions of WHAM that were taught. So some sessions were a little harder than others. We wanted to make sure the Fidelity didn't go down for those more difficult sessions. And I wanted to tell you a little bit about the second way that we measured Fidelity. Oh, I also wanted to mention that we'll share our Fidelity checklists with you so that you can see how we measured Fidelity. You're going to want to, personalize them to the particular way you're teaching the sessions. But the second way we measured Fidelity was through session recordings. With participants' permission, we randomly sampled group sessions, and our research reviewers listened to audio tapes of these randomly selected sessions to judge whether the principles of WHAM were being followed. It's one thing for the teacher to say, yeah, I followed the principles. It's another thing for an external observer to listen to the class and say, yes, those teachers did or didn't follow the principles. During the recorded sessions, we also filled out the checklists, and that enabled us to compare the reviewers' scores on the checklist with the teachers' scores on the checklist to make sure that they were rating themselves appropriately. So this, of course, is, if you can do this, this is a very important way of ensuring not just that individual elements are taught, but the whole philosophy of WHAM is being followed, that the principles are being enacted. Another important part about Fidelity is that we shared it during the weekly supervision meetings that we had with our WHAM teachers. This is also very important, just like people delivering other interventions in behavioral health. Supervision is needed and very, very helpful. And if we noticed that Fidelity was dropping off, we were able to give people retraining if they needed it, some refresher training, and we were able to make sure that overall the WHAM instruction that people got was high fidelity and also high quality. Here's a look at the participants of the folks in our study, and I am showing you this so that you can compare it to the individuals that you work with in the programs that you represent. We targeted programs for people with serious mental illness. So they had serious diagnoses of schizophrenia, spectrum disorders, bipolar disorder, and major depression. Around half were male and half were female. 2/3 were African American, showing that this is a culturally competent intervention. Around 1/3 were white. Most had completed high school or a GED. Most were not married or in a relationship, and many had additional disabilities or impairments. As I mentioned, everyone had at least one chronic medical condition in order to join the study. WHAM isn't limited to people with a chronic medical condition, but for our study, that was one of the foci. It was one of the inclusion criteria for our study. Very few people were working. Their average age was in their early 50s, and most lived alone. So if you work with a younger group of folks, maybe you work in an early psychosis program, I can assure you that WHAM is also appropriate for this age group and works just as well with a younger population as an older population. We did look at age, and we didn't find any differences between folks that were in their 20s and 30s and folks in their 40s and 50s. In our analysis of outcomes over time, we found that WHAM participants did show significantly greater improvement than control participants in each of our outcome areas. So the study was successful in that sense. They improved more in patient activation. They had higher self-rated physical health. They were more hopeful about their lives and their ability to control their lives and what their future was going to be. And they were also more likely to be gainfully employed. They weren't more likely to live independently. You may recall that was the second rehabilitation outcome that we followed. So they were more likely to be employed, but I think I would warn everybody that the percentage employed wasn't huge. It was significantly different from the control group. I think at the end of the study, the experimental group had about 20 to 22% employed. What I think is really important about this is I think it speaks to a very potent combination you could make if you combine WHAM with supported employment. I'm hoping that part of the series that that you're participating in will have a speaker that talks about evidence-based supported employment. You know, it's the intervention that helps people be able to work at competitive jobs that pay minimum wage or above, hopefully a lot above, and are jobs of their own choosing in the field that they want. We feel that if we had been able to combine WHAM with supported employment, we would have seen larger differences between the experimental and the control group, because WHAM alone isn't going to help people get a job. But the fact that more people worked, even though they didn't get supported employment, suggests that maybe this would be a potent combination if you have the ability to deliver both of these evidence-based practices. This research was published at the end of last year in the journal Psychiatric Services. And if you don't have access to a library where you can get a copy of that article, I'll be happy to send it to you at the end of today's presentation. I'll give you my email address, and you can just let me know that you'd like to receive the article. We also measured people's satisfaction with WHAM and found that overall it was pretty high. 97% said that they were either very satisfied or somewhat satisfied with WHAM in a general sense. 97% liked learning about the whole health topics, which is important. We want to try to make those sing for people, make those interesting. 93% said they liked getting peer support, and that was interesting because in the Georgia program, peer support was a lot more common. In the Chicago programs, a little less common. So it was, for some people, their first exposure to peer support, especially in a health context. 97% liked the goal setting, which again is a good thing because those are central features of WHAM. 98% liked the support group meetings, and slightly lower percent, but still pretty healthy, 83% liked the individual meetings. So overall, people were pretty satisfied with the content. They gave us some suggestions for improvement, and if we go to test WHAM again, we'll probably follow some of those. Some people felt that some of the sessions were a little long, for example. So we might have broken down some of those initial 2.5-hour sessions into smaller bites. We asked people to compare their health before and after WHAM. Now, this isn't scientific. It's not like measuring people's health before and after WHAM, because it's just people's own rating about whether they think their health improved. But we think it's interesting. 2/3 rated their health as being better after taking WHAM than before. 1/3 said it was around the same, and only 4% felt that it was worse. So in terms of self-perceived health, WHAM does tend to make people perceive that they're healthier. I wanted to say a little bit about recruitment in our study. Recruitment into any health intervention can be really challenging. And this is especially for people that have multiple co-occurring health conditions and don't feel in control of their lives, maybe don't feel that well physically. How do you get them to decide to engage in a health intervention? How do you empower them? And I'd like to share some of the WHAM recruitment strategies that we found to be effective in our study, but also these are recruitment strategies that we learned are effective from people teaching WHAM around the country. We held meetings to introduce WHAM to people. where we made it very clear that people were not going to be asked to change their personal habits. Of course, we hope they would, but that's not the focus of WHAM. Instead, we let them know that they were going to be asked to do something new that they really wanted to do. We also stressed that people weren't going to be pressured to do things that they didn't feel capable of doing. For some health interventions, people are told to do X or Y, and they just don't feel like they can do that. So their investment in the intervention is very low. They don't want to give it a try. We also stressed that WHAM's approach to reaching health goals was different because it was using science based on whole health and resiliency factors. And people were intrigued that they were going to learn about some scientific principles and whole health things that weren't just about physical health, but about both physical and emotional health together. We also emphasized that people wouldn't be judged and that they could change their goal if the goal wasn't working out. This was not a situation where they set a goal and if they wanted to change it, we would call that a failure or judge them or make them feel bad. Another effective recruitment strategy is using existing relationships with potential participants to personalize specifically what they might get out of WHAM. So, for example, one man was motivated to join WHAM because he wanted to dance at his granddaughter's wedding. And at the moment, he was not going to be able to get up and dance to an entire song. And so that was actually his goal, was to be able to dance with his granddaughter at her wedding. One woman wanted to look better in the dress she wanted to wear for her 20th high school reunion. And so that was her goal, not losing weight, but looking better in that dress. And it's helping people personalize what they hope to get out of WHAM, or really any health intervention that motivates them and to give it a try, even if they've had negative results in the past. Another effective recruitment strategy is, having WHAM graduates come back and talk to the group about what it was like for them to participate in WHAM and what they gained from it, what they enjoyed about it. It just helps motivate people, seeing someone from your agency or someone that's been through the program share how WHAM worked for them. And another way that recruitment often works well is if you're working with people that are in integrated health settings, if you can get the nurses or other medical staff on board by explaining WHAM to them and how WHAM works, they can encourage participation in WHAM from their patients because they know what kinds of physical obstacles and medical conditions people are dealing with. Once people join, the next challenge is keeping them involved in WHAM. It was a 3-month intervention, and we think that it had such an impact because people did stay in it for 3 months and worked on things for 3 months, kind of worked through some of their obstacles, which took people a while. So how do you get, we had people attend 10 out of 12 weekly sessions on average, and we worked very, very hard to make that happen. One way we did this is by offering to make up things in the individual sessions that if people had missed a group session. So I think I mentioned that earlier. One thing we found is if people fall too far behind, they feel out of step with their classmates and they feel like they should quit. They're not motivated to come. We also used the one-on-one meetings to see what might be preventing attendance. And the number one problem was transportation. That was the number one hurdle. And I'm sure you're familiar with that too. We encouraged people to buddy up and help each other share transportation to work. We also encouraged people to buddy up and give people support between groups, to call each other, again, only if they wanted to, the night before, to encourage people to attend. And this carpooling was something else that we encouraged people to do. as well as traveling together on public transportation. So these were some of the ways that we directly addressed attending the group and individual meetings. And it's okay to share with people how important it is to you as the teacher, as the clinician, as the peer, that they do attend these group and individual meetings, and share your faith that this will improve their health. Now, for those of you who are interested in training your staff or your workforce to deliver WHAM, the National Council for Behavioral Health offers training and certification by Appalachian Consulting Group trainers. I provided a link for further information about this training on this slide. And if you want to take a look at WHAM, you're not ready right away to go for the training, but you want to access the research version of WHAM that we tested. It's available online. I'll be giving you the link. The instructor and participant manuals are available in my center's Solutions Suite. The Solutions Suite is 18 free materials that are focused on integrated health and mental health care, and on self-directed recovery from mental illness.
What are you doing? That's okay.
I'm hearing a little feedback from someone, so I'll just, I'm almost on my last slide. So you can, I've put the link to the page where the WHAM manuals are available, and you can learn a little bit more about WHAM at that page. So finally, here's my contact information, the email you can contact me at if you want a copy of the article, or if you go to the Solutions Suite and have any questions about WHAM or any of the other 17 products that are available for free there. But what I'd like to do now is turn it back to Nick for some questions and some discussion. Nick?
Thank you, Dr. Cook, for a wonderful presentation here today. So we've already had a couple questions come in the chat. I'll start going through there, but if others have some, please feel free to add. The first question is asking if you could comment on the pros and cons of using peers versus case managers as leaders of WHAM groups.
So the intervention uses peers in part because working with a peer who's also faced similar challenges can be inspiring, can bring hope, and so forth and so on. However, you can teach WHAM without being a mental health peer. And so this is a great question. Thank you for asking it. What you have to be is a peer in using WHAM. So you can be a case manager, that's fine. You need to get trained in delivery of WHAM. You need to get certified in delivery of WHAM. You need to not use any of your case manager skills and behaviors unless they're already indicated as part of WHAM. But you do not have to be a peer in order to teach it. So I think I'll stop right there.
Great. The next question is asking for your thoughts about how you might be able to adapt the intervention for community mental health centers where there are 60 or 90-minute billing limits per day or per session.
That's an excellent, excellent question. Just take the sessions and split them. You know, split them into two, rearrange them, keep the content in the same order. And, you know, use some intelligence about things that would seem to hang together, but you can definitely do it within a 60-minute billing or even a 45-minute billing. It's just going to be a little longer.
Okay, the next question has to do with using WHAM in an early intervention service. In some early intervention services, people present initially still in very good physical health. What are your thoughts about using WHAM as a preventative intervention for health concerns?
Oh, that is so interesting because everything they're learning in WHAM is really designed as an upstream preventative intervention. We tested it with a group of people who already had developed a lot of chronic conditions. One thing you should know about WHAM is there's not a lot of you have this chronic condition. In fact, there's no you have this chronic condition. Another thing about WHAM that I didn't really emphasize because we focused on people with medical conditions is your health goal can be anything of the, let me go back here. Hope I don't make anybody dizzy by going through these so quickly. Any of these resiliency topics. So for example, you might want to work on your spirituality, okay? And you might want to work on developing whole health by adding meaning and purpose to your life. You might want to work on becoming more optimistic. All of these are whole health and resiliency topics. So for people that don't have poor health, don't have a lot of chronic conditions, these are things that you can focus on. Now know that restful sleep is related to having a life with meaning and purpose and so forth and so on. But I think I would be focused on the whole health and resiliency areas that were less physically health oriented. So I hope I've been clear about that. I tended to focus more on how we tested the intervention for people with chronic medical conditions, but it doesn't have to focus on that. And the curriculum doesn't assume that people participating in it have chronic medical conditions. So that's what's important.
So I knew this next question would come in at some point right here. With COVID, can WHAM be delivered via telemedicine, and are any modifications recommended?
Try it and let me know is my answer. I definitely think that this can be delivered via Zoom, for example. We haven't tested it, but I'm working on a project right now where we're using Zoom to do RAP with seniors. So I think if you're a skilled Zoom intervention provider, you can definitely adapt this curriculum and deliver it in that way. And I think many, many people would benefit from it right now. And so I would encourage you to do so, and please email me and let me know how it goes.
Great. Now, it looks like we have one last question here today. Were you able to examine whether there were changes in cognitive functioning associated with participation in WHAM? And could the potential improvement in cognitive abilities due to improvement in physical health maybe play a role in the improved work outcomes in this group?
That's a really interesting question. And we didn't measure cognitive functioning. There were so many things to measure. And so we didn't really measure it. We did tell people that the structured goal setting helped them think more clearly when they set goals, when they chose things to work on, that the 0 to 10 rating helped them learn how to be more thoughtful when they, thought they could do something every day and then they tried it and they weren't able to do it. So they described some cognitive changes to us that that might be implicated in being caused by WHAM. And the link to the employment, I think, is very, very fascinating, and actually is one of my kind of pet hypotheses about this. The other thing we found about WHAM was that people were motivated to do things like one gentleman told us, I don't wear my glasses because I don't like them, but I knew I couldn't come to WHAM and take the classes and do the individual meeting without them. And now that I'm wearing my glasses, I'm like, I shouldn't go through life without my glasses on. That's a level of cognitive organization, that I think is really, really important. I don't know that it comes from WHAM so much as participating in a structured intervention that involves both group and individual interaction. But I mean, he was describing improvement in executive functions related to being able to see better. So I think that's a really intriguing question and interesting idea, but I don't have any evidence on it, unfortunately.
Well, Dr. Cook, thank you for a wonderful presentation here today. As I anticipated, we also got requests on the chat for copies of the slides. So if people are interested in that, please send an email to us at our epicenter@osumc email address. And in fact, I will type that into the chat now so everyone can have it, and we'll be happy to share those, which of course include those wonderful links to the resources that Dr. Cook has on her center's website. So we'd like to thank everyone for joining us today. Hope you all are staying healthy, and hope you'll be able to join us next week when Lena Palyapan will be presenting on cortical reorganization in early psychosis here. So take care, everyone. And Dr. Cook, thank you again for a wonderful presentation today.
Thank you. Thank you, everyone, for attending today.